So good evening, everyone. Welcome to this Diabetes Africa event series called Everything You've Always Wanted to Know, where we're going to be talking about many things that impact people of African and Caribbean origin when it comes to their diabetes care, and providing information, resources, and interesting discussion topics for the healthcare professionals that care for people of African and Caribbean origin. Diabetes Africa is a non-profit organization. We were established in 2019, and our goal is to improve diabetes care for people based in Africa, but also people of African origin globally. And we do this by communicating, connecting people, and part of what we do like this is to raise topics and increase awareness about things that are very important to diabetes care. This session today, this event today, the first in the series, we're going to be talking about how to have more comfortable conversations. And that could be about anything related to diabetes care or even wider, because we have to acknowledge that it can be slightly uncomfortable to talk about issues or broach topics with somebody who's not of the same culture or ethnic background, because there's different aspects that are involved in that. And we wanted to get to the root of that potential challenge and have an open discussion about it. We're very keen on things being proactive, so there'll be tips and advice as we go through. And as always, please put your questions in the chat. People will be there to have a discussion with you. We'll also have an opportunity at the end, near the end of the event, to answer people's questions. I'd also like to say a big thank you to Novo Nordisk for supporting this event series. Novo Nordisk hasn't had any input into the agenda, the speakers, or the content, but we massively appreciate the support to enable us to have these really worthwhile conversations. Great, and now it's time to hand over to Dr. Natalie Darko and Dr. Sam Siedu for the next part of the presentation. It would be great if you could introduce yourself, please.
My name's Dr. Natalie Darko. I'm an associate professor at the Stigma Research Centre at Oxford University in Leicester. I've been working within the field of health research with ethnic minority groups for quite a long period of time, and I've completed extensive research around diabetes intervention and care.
Thank you, Natalie. And Sam?
I am Sam Siedu. I'm a practicing GP in Leicester City and a clinical lecturer at the University of Leicester. Within the diabetes field, I'm a faculty member of Primary Care Diabetes Europe, and I currently chair the research arm of the group. And in the UK, I sit on the Primary Care Diabetes Society board.
Thank you, Sam. Please go ahead, Natalie.
So basically, I've got some set of slides that we're going to share with you where we're going to discuss what cultural competency is. So we're hopefully going to give you an understanding of cultural competency, but within the context of African and African Caribbean groups, with a focus of some of their core definitions and concepts within this area, but also some case studies to help you within your own practice. So to begin with, it's important to understand what cultural competency is and its boundaries, but also understand why it's important for health professionals to be aware of cultural competency and how this can impact on diabetes care. I'm sure many of you have done have some understanding of cultural competency, but also have done some training within this area. So today our focus is on looking at that in more depth, but most importantly, how it applies to African and African Caribbean groups, and also why it's important to be aware of it and how to utilize it in your own practice. It's important because research shows us that cultural competency is important particularly for improving diabetes outcomes, particularly for different types of patients from ethnic minority groups. So if we move to the next slide, we can look at this in more depth. So now when we look at this, it's important to understand what the meaning of race, ethnicity, and culture is, and also making sure that we're clear that they're not the same. So importantly, the difference between race and ethnicity. What does it mean if we look at it in terms of cultural competency? When we look at ethnicity and recording data, particularly health records, we focus on ethnicity as an indicator of race. However, when we look at it in terms of cultural competency, we want to separate the two. So race referring, for example, to your skin tone or skin color, and ethnicity, focusing more on the cultural aspects of your ethnic group. So it's important to understand the difference within cultural competency, or to be culturally competent. So what does culture mean? Culture focuses on patterns, human behavior, your thoughts, your communication. It could be your language and practices. It can also be your beliefs, your values, your faith, your customs and norms. And also it could be rituals and manners of interacting. It can also be about roles, relationships, and expected behaviors. So as part of one's ethnicity, we need to understand culture, but also make sure that we're clear that it's different to a person's race. So we look at this for the next slide. Why is it important? But also, not only why is it important, it's important to understand what cultural competency means and the different boundaries. We need to think about this because there's lots of terms around cultural competency, such as cultural sensitivity, cultural appropriateness, and cultural awareness, and cultural tailoring. So if we try to understand these, it's important to help us move closer to cultural competency. And we'll look at these shortly. But if we come on to the next slide, where we look at why it's important to be culturally competent in our practice. We want to be culturally competent in our diabetes care, diagnosis, understanding, and other pathways such as social prescribing, because we can help to reduce disparities and inequities and inequalities in diabetes and access to diabetic care. Importantly, we can perhaps change some of the outcomes for patients, but also try to understand why there are differences in medication, diagnosis, etc. But also, it will help us to understand racial bias and racialization that results in inequities. As we move to the next slide in a moment, we'll look at the notion of color blindness and what happens when we try to categorize different ethnic groups, notably African and African Caribbean groups, into one group, such as a Black group, and what happens when we do this. To be culturally competent, we want to try and move towards a delivery of what's often referred to in the United States as anti-racist practice, but most importantly, health equity. So we can perhaps try and understand why there are differences in diabetes diagnosis and outcomes, but also try to address the barriers that individuals may experience in accessing diagnosis, screening, and treatment. So if we look at the terms for improving cultural competency, or terms surrounding cultural competency, this can help us to understand how we get there. So if we move to the next slide, there are various terms that you'll all have heard, and many assume that they mean the same thing. But cultural competency, in its basic form, is an increased understanding and appreciation of cultural differences and similarities within, among, and between different groups. This includes systems. It can include a reference to systems, interventions, and services. But to be culturally competent, you have to have an understanding of people's culture related to their ethnicity or ethnic group. Cultural appropriateness focuses more on the sensitivity to cultural differences. So we want to encourage you to think about differences and similarities between ethnic groups, and particularly for African and African Caribbean groups, and the differences that occur between them, but also within that African or African Caribbean group, between islands, if, for example, an African Caribbean person and their heritage, and between different countries and origins of heritage for an African patient. So we need to be sensitive to these, and we need to translate that into our sensitive action. Cultural awareness is recognizing one's own and others' cultures. So we need to be aware of it, but we may not be culturally competent. So leading to cultural competency, we need to have an awareness. Sensitivity is about understanding the needs and emotions of your own culture and others' cultures. And if we think about humility, this encourages us to be self-reflective and self-critical. So be aware of your own ethnicity, your own culture, and how that may impact on your interaction with a patient or your interaction with an individual in screening. And then finally, there's cultural tailoring. This is where we recognize our cultural competency and the differences and are sensitive to different cultures, but we then want to tailor our practice or interventions, our training and our materials to be more focused to different characteristics of that ethnic group, particularly between African groups and also African Caribbean groups. Moving forward, one of the important things to think about, there are lots and lots of different approaches to cultural competency within the NHS and more broadly. But one of the things that we can look at, which is pretty simple to follow and understand, is the continuum of cultural competency. And it's developed in the US, but it's a great starting point for developing our own cultural competency in practice. And key themes within the continuum are to look at cultural destructiveness all the way to how we become more culturally competent. So when we think of cultural destructiveness, we need to think about the notion that we are ignoring rights and privileges and that a dominant group exists. So if we tend to focus our diabetes care on a particular group or a white majority group, we then are being destructive towards those other groups, African, for example, and African Caribbean groups. If we have incapacity, we then to maintain stereotypes and practices regarding those individuals. So we may assume, as we'll discuss later, that that individual, for example, is hard to reach, or that individual doesn't engage with guidance or advice and guidance surrounding diabetes care or screening. This moves on all the way through from cultural blindness, leading us up to cultural competency. So in a way, with the next step, differences are ignored and we treat everyone the same and the dominant groups are only met. So in my experiences of delivering type 2 diabetes community-based interventions for African and African Caribbean groups, it was evident in the data collected that lots of the perspectives were that most of the services they tried to access within the region were targeted for a dominant group and didn't respect their differences regarding food, lifestyles, religion, faith, etc. So as we move through the continuum, we're working towards cultural competence. And then finally, which is very important about cultural competency, is that when we assume we're culturally competent, it doesn't stop there. Our awareness needs to continue, and we need to continually be self-reflective and review. So we recognize individuals' cultural differences, but we may, in our cultural competency, seek advice from diverse groups, from African and African Caribbean groups, and then continue to improve that practice. And what's important about culture and ethnicity, and most importantly culture, is that it's not static, it always changes. So what's relevant to an ethnic group regarding their culture in 1 month may change considerably, particularly for African and African Caribbean groups in the next month and in the next year, etc. So to be culturally to achieve the end of the continuum, we need to be aware of that and make our changes and recognize differentiated needs and that they're context and time bound. So if we move forward to the next slide. What is cultural competence in the context of diabetes care, and how can it help healthcare professionals like yourselves support and meet the needs of African and African Caribbean populations? So cultural competency is often targeted to all ethnic minority groups, but what does it mean in the context of African and African Caribbean groups? As we've mentioned, there are different boundaries that focus on a person's norms. It could be faith, religion, it could be diet, it could be daily practices, it could be festivals, etc. So we need to have recognition of this. So if we move forward, we can perhaps look at some of the data I've collected and what that means and how it translates into our practice. So classic examples from the research I collected with different African and African Caribbean groups, key quotes from their perspectives on how they've experienced diabetes screening for pre-diabetes and diabetes care, is common quotes or common thoughts and perspectives that came up were that I'm not hard to reach and that I don't want to be perceived that way, but also it's more that the services aren't reaching them. So it's important to recognise that the service provision shouldn't focus on that notion of cultural assimilation or that notion of that there's one dominant group, but should be targeted and tailored to different groups. And within the research, African Caribbean females in particular requested activities that are relevant to their cultural practices. So, for example, dancing, soca dancing, for example, foods that they eat and activities with other African Caribbean women and other groups that were respective of their tradition and cultures. In relation to African Caribbean males, some of the core quotes that came up within my own research were recognize the importance of that person's migration journey. So, for example, An African Caribbean male within the study had originally moved from the Caribbean as a young person. When they moved, they talked of different experiences with healthcare professionals, but also different wider organizations, and the trauma of the experience of being a Caribbean person during the time or the period of the Windrush and being treated differently and experiencing periods of racism, marginalization, and distrust. So those feelings were echoed throughout their life, but also impacted on how they perceived healthcare services. So working with those individuals to understand their journey or be respectful to these experiences is important, but also the trauma of those experiences impacted on how they engage with healthcare professionals. So things to think about when we consider the narratives of different groups is the perceptions of healthcare and healthcare staff and notions of distrust. Not always are there experiences of distrust. There are positive relationships, but it's important to acknowledge where those perceptions come from and how they feel. The importance of tailoring interventions that recognize a person's culture, belief, faith, and religion and their migration history is really important. And there are references within the slides where you can look at this in more detail. But most importantly, the key point that we want to take away when thinking about cultural competency is the importance of stigma and language. If we use terms such as hard to reach or assume that African and African Caribbean patients are difficult to engage and difficult to reach, we create a stigma or a label of that group, and we then indirectly see them as a difficult group. Whereas the data tells us within my own research and other studies that this creates further barriers for them. And also we need to be more positive in our cultural competency towards these groups. So if you come to the next slides, there are references where you can look at this in more depth. So now we're going to come to Sam and talk about case studies where we can apply our practice.
Thank you, Natalie. So I've got 3 selected case studies that I've picked from my own clinical practice. Real cases that I've seen that we can adapt your theories into helping manage or solve the problems that we encounter with these sort of patients. The first one is a 56-year-old gentleman, newly diagnosed with diabetes and is declining to start medications, even though the A1C was high at diagnosis. And when the healthcare professionals try to explain the necessity for starting treatment and lifestyle interventions and medications, his reason for refusal was that God was in control and everything will be fine. So the discussion points are, Natalie, what is the healthcare professionals' view on the attribution of the cause and effects to God? Now, so listening to what you have been talking about, we need to be aware that that person's culture hinges a lot on God, religion, that plays a vital role. So to be able to engage this patient in their management plan, we cannot ignore that belief system. So that may well be it may well be the fact that we also are believers or non-believers, or we do know that African people tend to be more religious. But that's the knowledge. We then need to move on to that awareness, okay? Being aware is how you shift that knowledge into changing your own perspectives or the patient's culture. Are you willing to change your own, position to adapt to their position to help them manage their diabetes? Is that something you're willing to do? And there will be strategies of achieving this. You might want to suggest to the patient that, yes, we do know that God is in control and God is going to help everything to come out all right at the end of the day. However, it's the same God that is using me to speak to you regarding your diabetes management. And so you are actually playing back into the patient's field rather than saying, no, this is medicine, this is the evidence, God doesn't, have a role in this, that you cannot get the patient to engage at all. And I think to come to that position where you'll be able to talk like this, you've got to accept that there are sensitivities in this issue. And that is what, Natalie, you were talking about, cultural sensitivity. It's about not attaching a value one way or the other to the other person's culture. You're not saying their culture is inferior or superior. No, it's just different, full stop. And if it is different, how do you then work around their culture, adapt the intervention that you have, and to get them to ultimately take up the intervention that is evidence-based? And the only way to do that is, in my opinion, to work around their religion. You cannot brush it aside. And like I suggested, playing it back in their field by suggesting that God is using you to reach out to them. That is a very good way to handle such a thing. Non-engagement becomes an issue. Again, you've got to set goals. If we want to go by the assimilation method that you talked about, it's standardized. Doctors will, set a target for the patient. And if the target is not being achieved, you get the patient to come back within 3 months to 6 months for the A1C to be repeated. Or if it's well controlled, maybe annually during the cough years to repeat that. That may not necessarily work for this patient. You have to find a way of engaging them, especially when they believe so much that God is in control. You've got to find a way of, adapting your review periods to fit their belief system and their attendance for the follow-ups. Next slide, please. Next case study. So the next one, again, is another real-life patient I've seen in my practice, 44-year-old woman with poorly controlled type 2 diabetes that needs to start insulin. So the decision has been made that the A1C is so high, the patient is osmotic, and they need to go on insulin. Now, the difficulty with a situation like that in most primary care centers is that time pressures are a hindrance to initiating injectable treatments. So what are the options you have? The patient doesn't speak very good English, struggles with British accent, so when you speak, the comprehension is a huge problem. So the real challenges for the healthcare professional in situations like this is you are running late and you want to get this, done with, there is a temptation to cut corners. And these are some of the reasons that we are seeing the health inequality, the widening of the gap between the outcomes between ethnic minority patients and white Caucasians, because it's very easy for you to just give up on a patient like this because it's so time intensive. The need for getting interpreters around, other patients are waiting when the consultation is taking long. And indeed, let's face it, it comes with an increased health resource utilization if you have to, take all this into the equation to manage that, patient. So there is a temptation to just give up and say, you know what, I just can't fix it. I can't solve all the problems in the world because if they can't speak English, that's their problem. You've been in this country for the past 20 years. Surely you should have assimilated. But again, that is what, Natalie, you were talking about. If we expect that because the person has been around for a while, they should be able to adapt the majority culture, so that leads to cultural destructiveness of the minority cultures. And if you did that, if you took that approach, what actually happens is that the minority cultures will only be playing catch up. You can never be the best, of yourself, because it's somebody's culture you're trying to imitate, and you can never do it as well as they can be. So if we want to talk about health inequalities, let's talk about it. If we think that, we want to close the gaps between, our minority groups and majority groups, we've got to really face it. That is one of the biggest concern. We either accept it that way, or we just, say, yeah, we're going to have to recognize other cultures as being as important and not assimilate them and destroy them. So that patients may be using a lot of resources, but you look at the whole global picture of their contribution to the health economy, and you might find that actually the reason why you do need to bend backwards and support them is because they are useful in other sectors. They may not be useful in the health economy, but that patient that you see in there might actually be the carer in the nursing home next door, a job that nobody else would do. And if she got that diabetes and she dropped dead, it has a knock-on effect on the whole population. Let's face it, there are some jobs that other people will not do, and some people will do them. The odd night shifts, the odd care home jobs. These are the sort of patients that you see doing those odd jobs on a minimum wage. And then finally, the third case is a 49-year-old patient with type 2 diabetes, a warehouse operative and a security worker. Misses frequently and has been discharged from follow-ups because of exception reporting. Okay, again, similar to the first one, that's a very easy one for us to give up on as healthcare professionals. You see this patient and think, well, I've called the patient several times. The patient is not turning up for appointments. I've sent 3 letters and they are not coming up. So, A1C is high, blood pressure is poorly controlled, lipids all over the place, and they are not on statins, and they're not coming. So the easier option will be to exception report this patient and give up on them because you've tried your best. Now, if you want to dig deep and see what is actually happening, like I said in the previous case, that patient is a warehouse operative, the security person. So they have to do these 2 jobs to keep their homes running. And so they do the night shift and they come. There is no way they can even remember to come for an appointment. These are some of the real challenges. And so they know they have to come, but, the health sort of takes the backseat, especially when they've got young kids to look after. You don't think about yourself. You just wanting to do the best for your family. And if you're a breadwinner like this person, that's what you're thinking about. The next shift, the next hourly rate in the warehouse. Is he going to be able to pay the bills? The last thing he thinks about is the diabetes, unless the complication happens. And so how do you resolve this as a healthcare professional? Well, there could be other ways to consider. You might want to get more flexible opening hours. These days, people do extended hours, extended access. You might want to consider, offering one of those slots to this patient. Remote consultation is now becoming a big deal now, especially in this day and age of COVID. You might want to find other ways of engaging with this patient remotely rather than getting them to come to the surgery. And if it means that the patient remotely cannot be initiated on an injectable, you might want to consider an oral alternative for this patient. And so those are all the options that we've got to consider. But to get to the stage where you want to consider this alternative, you've got to be aware. You've got to, first of all, have the cultural knowledge that this person is probably not as privileged as you are. They have to do these odd jobs in these places, earning a minimum wage in order to be able to survive in the society. Then, having got that knowledge, you've got to be aware, and that awareness is, what are you willing to do? Are you willing to shift your position to address this patient's cultural hindrance to their diabetes care? And then thirdly, that sensitivity, the cultural sensitivity, being aware that this patient's lifestyle does not make them any inferior to you. Their inability to turn up for appointment doesn't make them hard to reach or non-engaging. Okay, just appreciate that and then consider the other options I've already talked about.
Yeah, and I think that last point is important, Sam, because one of the important things within my research and work is understanding the nature of caring for your own, not only within African Caribbean populations, but also in different African groups. The notion that on top of working and on top of doing the other things, traditional practice is about caring for your own family and taking on the responsibilities on top of your existing priorities. So adding that into their time to meet with you, that individual particularly may prioritize caring for their own as opposed to making and caring for their own health. So research with the females that I've completed and African Caribbean males is that their family comes first. So recognition of that and understanding that as a healthcare professional and having that empathy as opposed to seeing it differently is really important. So yeah, that's an important case study, I think.
Natalie and Sam, firstly, thank you very much for the presentation. You run through some key points, very interesting points. One aspect that we haven't touched upon is how perceptions might come into this. So I know from personal experience and people who know me, I'm normally quite animated, a person and things like that. And I wonder whether you had any experience of people living with diabetes being misinterpreted in their animation. And also putting it in the flip side, I know in many African cultures and also in the Caribbean, there's a sense that the doctor is like a secondary god. So people might be a bit submissive when they're talking to the healthcare professional. Is that something that you see in practice, Sam? And Natalie, has that come up in your research before?
Yeah, so for me, in the case studies, particularly with the African Caribbean males, but particularly the elders, there was the perception that the diabetes specialist or consultant, whatever they'd said or recommended was just followed, and that they didn't want to interact too frequently with the service and that they were fine, which often resulted in problems not taking medication. So medical adherence was problematic for them because they just assumed they were told at the start of the year to do something, and then that's what they've been carried on doing, despite changes in their health and other conditions had developed. So there was that notion, and also the notion that particularly within Caribbean groups, that their expression of and way of expressing their experiences, or that they didn't want to change their diet, was very expressive and aggressive. Whereas to them and within cultural practice, that seems like a standard form of behavior and interaction, but it's not aggressive. It's just a way of communicating. So yeah, misconceptions around that practice and interaction and different ways of interacting are important. And also for me, within my research, dialect has the tone of the dialect can be very loud at some points, whereas to a person who doesn't speak that dialect, to the outside person, that loudness can create anxiety in another person or come across aggressive, but it's just the tone and the pitch of the language and the dialect as opposed to that person's being aggressive. And misconceptions can come across. And as it's translated for many of the individuals within my research, it's passion for health or passion for their way of doing things.
I think the other way of looking at it as well, Natalie, it's not so much that they are aggressive. It's sometimes frustration as well.
Yeah.
Because of that notion that they are hard to reach or they are not engaging or whatever labels that we want to give them. And they know they're trying their best and they can't access the services, they get frustrated. And so in trying to get a point across, I just want to be heard. Can somebody just listen to me? So that comes across as aggression, but no, actually just frustration. And that can come out across, as aggression, but it's not. The other thing that you mentioned, Benny, is those that come, on the other side of the spectrum, a lot more quiet. Again, we talked about cultural sensitivity. You've got to be aware that somebody who doesn't speak as fluent a language as you or in the same accent as you do doesn't mean they're inferior. So avoiding adding a label to their culture makes a difference to the way they perceive themselves. Okay, if you judge them because they've got a different accent or because they cannot speak a fluent language as you, they must be inferior, of some sort. What they actually come across, if it's happened to them a few times in society, what they actually get ingrained in their system is that these people are going to see me as being lower because I don't act or speak like them. And so when they come, the least they will do is what they can do not to express themselves. They will just keep everything inside. In other words, they don't want to express themselves and show their inferiority, which you know about. And so they come sitting in your consulting room, a bit, tacit, not talking very much. That's not because they are hard to reach or they are not engaging. They're probably just conscious of what you think about them. And some might actually just do it out of respect. Some, cultures, they just do it out of respect for the authority. And so when they're in your presence and they're quiet and listening, it's actually out of respect for you. It's not because they don't want to engage with you.
Yeah, I would agree with that, Sam, as well. And that can be trying to be respectful. But also, I think coming back to the case study in relation to this point, again, lots of the work that I've done showed that, for example, individuals who were struggling with accent and had been frustrated or not listened to, clinicians had worked with them to suggest bringing another person from their family or network who could help translate those experiences, and also evidence where, for example, that individual had been taking their medication or not been taking it, and have the discussion with them and build up the communication and the relationship between the patient and the clinician. And I think that's important as well, because again, building in your cultural competency and to continue and not just to stop, to become proficient, is about recognizing outside help, diverse groups and other groups, not just yourself, but also within that patient's network. And I think that's important because, again, you might have the timid patient, but the family member or relative may have a different approach or different style of communicating, so that it allows you to develop that relationship. So I think that's important.
Thank you for that. That was, really clear explanation and gave a lot more information about the rationale and some of the behind the scenes. Another question that came in is about, are there any reasons why people of African or Caribbean ethnicity are hesitant or have a poor perception of healthcare? And I think it's important to answer this question because for me, it forms the foundation of any interaction, what people are bringing to the consultation. So are there any specific things from history that you think might be, that could add to that or could cause that perception?
So again, Bernie, there are historical facts in America that have made people very dubious about the healthcare systems. We know about the Tuskegee experiments and all sorts. So historically, Black people in the Western world have always been very suspicious of, the health service. And it takes a lot of trust building to get people to come across. And it's a huge hindrance to getting the outcome that we want them to get. I think one way of dealing with that is to expose them to healthcare professionals that look like them. I mean, if you see somebody who looks like you offering that, intervention to you, you're not going to suspect that they are out to get you. Unfortunately, those opportunities are also very limited. It's not many healthcare professionals who are available out there that look like them. The vast majority that will be out there are, in the positions where they cannot be making those decisions. They are either the ones doing the cleaning on the wards, or, the HCAs, and, they are not the ones that are at the top level who will be making those decisions. And so all of these structural hindrances in time will have to be dealt with before you can rebuild that trust that is of historical dimensions.
And I think if we look at it in the context of COVID at the moment, and within the research I'm doing at the moment around this area, is perceptions of inclusion historically and currently in trials. So whilst due thanks to media reporting and public discussions, ethnic minority groups are more aware that they've not been included or have been a minority within clinical trials for different medications, whether it's vaccine or other medications. So that then sticks with an individual and then encourages them to perhaps see their medical profession and the medication for them differently. And so it's about working on improving inclusion, but also trying to be aware of that understanding. So having an awareness of those perceptions and trying to work with them, and having clinicians like Sam, who represents African ethnic group, but also has an understanding to show that individual what's changed and what's changing in the data and discuss it. And I think that helps. Being culturally competent is about being aware of the historical inequalities and inequities and not ignoring them, but recognizing them and being understanding for your patients. and moving forward. I think that's really important.
Wonderful. Thank you, Sam. Thank you, Natalie, for that. Now we're going to be joined by Hindi, who's a person living with diabetes, to hear, a lived experience. I won't introduce you. I'll ask you to introduce yourself. So can you tell us a little bit about yourself, please?
Okay. So my name is Hindi Kora. I'm a mother of 3, 2 girls and 1 boy. I live in Milton Keynes. I'm registered nurse by profession, so I've worked through the various specialties, but now I'm a school nurse. I work with school nurse in Milton Keynes. And I'm Ghanaian by birth. Yes, yeah.
Wonderful. And what has your experience been during consultations? Do you feel that the healthcare professional team had a good understanding of your culture and background? I know your situation is slightly unique in that you're also a healthcare professional, although you say your specialty is not in diabetes. Mm-hmm. But when you're having conversations, were people or your healthcare professional team aware of the type of foods that you ate or any of the cultural belief aspects? Mm-hmm. And if not today, were you asked?
No, I wasn't. And that's because we all preach eat vegetables. Or, don't eat too much carbohydrate. And then African foods are heavily carbohydrate foods anyway. So when you go and it's like, oh, vegetables. And also because these are my colleagues, from cultural background, you don't want to look as if you're eating all this carbohydrates when you should be preaching it. You preach your patients and everything to eat vegetables and all that. So when you go and see your colleagues, you don't want to tell them, actually, all I eat is rice. So during consultation, you want to look good. So they'll ask you, do you eat vegetables? I say, oh, yes, I eat vegetables. But they don't go in depth into what I eat. But on the flip side, when I'm talking to like patients or parents, I would say, what do you eat? But I know, because that's my background, I would ask personal questions, so I know what to ask them. So do you eat the fufu or do you eat the banku, things like that. So they know, I know what I'm talking about. But culturally, some of them probably will not even tell you, because there's already a stigma asking like, oh, that's all they eat. So they will not even tell you. But if you put yourself in the whole equation and say, oh, actually I like fufu, I do eat fufu. But sometimes I do, cut down portion size or add something to it. And I've recently I've got a few friends in the community who would come to me. And just last week, somebody came to me and said, oh, I've only just been diagnosed with diabetes. So what do you eat? Then I can have that conversation with them. But this lady is illiterate, so she can't read. So I asked her, so what did they give you? So they just gave me some booklets. And I said, you can't read. Did they explain it to you? She said, no. And I said, have they sent you on the Desmond course? She said, no. So I said, okay, then you need to go back. But she's got her daughter who usually comes back to me and asks me questions for that. And so I've just spoken to the daughter and I said, can you get them? Because she needs to sit down and actually listen to somebody tell her or explain to her. So that's why I suggested to them. So she can't read. They're giving her all the leaflets. She's on metformin. She hasn't got anything to measure her blood sugar. But she's back home. But she's got cancer and she's got diabetes now. So with her case is, quite dire as well. So these are some of the things that you face. They just need the booklets. Nothing to back it.
Hindi, what I'm hearing actually is, so the fact that the questions weren't asked during consultation, that's even for you and for your friend, meant that some of the treatment aspects weren't optimized, such as giving someone leaflets who actually can't read. And then the person might go back and the healthcare team might think that the person's not engaged. It's not that they're not engaged, they couldn't read the material. So I hear you when you say there's those barriers. So it's already a difficult topic, and this event is called having more comfortable conversations. Often getting that trusting relationship and being able to broach the topics takes time. If you've got 10 patients waiting, you're already 10 minutes behind schedule. You know that certain patients are going to start complaining because they have their own plans and now you're making them late. And there's all that pressure on the situation. And then the person's trying to have a delicate conversation about beliefs, perception, etc. That can be quite difficult. And actually, I'd like to open it up to Sam, Nasli, and Hindi altogether. This topic for many people is very scary and overwhelming, and will often case be very new in terms of how to have cultural competency and how to broach that in consultation. So I'd like to come to you first, Natalie, please, because you've done a lot of research on this. What are some of the ways that healthcare professionals can broach these topics or this area and open up a conversation with the person during the consultation?
I think the most important thing is as academics and clinicians, we use lots of terms. So even using the term cultural competency or medical adherence or anything, that for as a starting point can be difficult. And as Hindi's just pointed out, literacy levels, or as we call another terminology, health literacy, is difficult for patients, and also within African and African Caribbean groups, recognizing or revealing that low health literacy or low literacy would add stigma and is most probably not revealed. So I think it's important to look at how you have the conversations and try to understand the individual. So it's clear, as Hindi said, it's trying to work with that individual to not ask that person if they can read the leaflets, but give them alternative methods. So for example, here is a leaflet. Here is a colourful infographic food plate that's culturally tailored to your particular diet. Here is an organisation working in this field that works with African and African Caribbean groups. And here is a video. And here is etc. Or how can we work together? Or Hindi mentioned the daughter, I think, or a relative. Would you like to bring a relative with you in your next consultation? Do what you can in the time, but being aware of how to adapt your practice to make it more culturally competent without using the terminology and all of the things, but also having those alternative methods of communication to not identify that person has low health literacy, but to address and make the service equitable rather than equal. So equitable being for individual adaptations as opposed to making it more equal and assuming that we can create the same approach for all groups. So that would be my key starting point.
Sam, you're on mute.
It's a fantastic point, Natalie. I was itching to say the same thing. And it's all about the cultural awareness that we've been talking about all afternoon. The cultural awareness, you've got to be aware of your own position when it comes to cultural issues, and then you'll be willing to adapt your perceptions. So this person that gave the leaflets, if you go and read what they've written on the computer system, they would have written there, leaflets offered, patient information, leaflets offered to patient, take. So everything is ticked as having been done, but the outcomes are still going to be bad because this person is not going to read the leaflets. And so until you get aware that, yes, there are time pressures, but just handing over the leaflet to somebody who cannot read it or understand it is probably not sufficient. And then adapt your intervention to include various options like using the video, using the family members, and so on and so forth, as you've enumerated. I think that is a way to handle it. The other thing about the awareness that Hindi has talked about is, even as a healthcare professional, she knows what she eats, but she was a bit kind of hesitant going to reveal what she eats to her GP or her nurse. The question is, why is that? And the why, if you want to dig very deep inside, for those who are not even healthcare professionals, the why is that subconscious knowledge that has been drummed into your head over the years by the society that what you have is probably not at the standard that it's supposed to be. And that is what we're talking about. It's about the assimilation that we expect people who have come over to adapt a certain standard of living, which is the UK way of doing it. So yeah, we can do that, but we cannot do that and at the same time complain about variations in outcomes. Because if you want to be serious about variations in outcomes, you've got to appreciate that the cultures are different, not necessarily bad or good. Do not attach a value to a culture. Once you do that, and the society accepts that, then the person who is of the so-called inferior culture subconsciously does not want to show their culture outside to their healthcare professional. They would rather hide it and go and eat whatever food or banquet they want, whatever countries they want. And so it's an interesting point that you came up with. But even as a healthcare professional, if you imagine those who are not, and they are not health literate as you are, it's even worse.
Absolutely. I would like to push a bit further to see if Nasi, Sam, and Hindi, if we can come up with one question that the people in the audience could take away, one question each, that the people in the audience could take away if they're trying to broach some of the topics and areas that we've spoken about, if they are feeling uncomfortable in the conversation, they're not entirely sure what's a safe way to open up the conversation. So, Hindi, you haven't spoken, so I'm going to give you the tough task of going first with your first suggestion for a question.
Okay. I think what Sam Naki said was echoed what I was going to say anyway. But I think one of the things that stands out for me is most of the time, healthcare professionals, when the patient comes in, it feels like you and us, so that already there's a gap there. So they always think that you know more, and then you probably, tell them off for something that they haven't done. But if you make them realize that at the end of the day, we're all human, we all make mistakes, we all do some things that we shouldn't do. So they need to know that you are talking from a personal point of view. So if you can give them a scenario to relax and say, listen, my aunt's got diabetes, so it's something that I'm aware of, and it's in the family. They can just relax. That alone can make them feel that, okay, she's seen it before, it's in her family, so she's used to people like me. Rather than feeling that, it's you and us, I'm telling you what to do, but, you have to listen to me. So if you let them feel that, we are all in this together, I know what you're going through, I've got experience of that, and it's in my family, I've seen it before, it relaxes them. So maybe that's how we can actually approach it sometimes, not to let them feel that they have to just listen, but they need to know that you've also seen it before, and it's very personal to you.
I like that, Hindi, because it's not necessarily a question, but it's acknowledging that there sometimes can be a them and us feel when someone walks into a consultation. And as we spoke about in the previous session, people might have some perceptions coming into the room about healthcare, about the hierarchy of the relationship. So being more personable and saying, okay, I've had this situation, just to relax or make it more open to dialogue. I think that's a great strategy. Thank you, Hindi. Sam, I'm coming to you next. You're on mute again.
It's an interesting one. How do you start a difficult conversation? I suppose it's about knowing the person, pre-planning. You cannot start a conversation without knowing where they're starting from. And if you know your patient, the patient coming has got these issues, I think that is where you got to start from. If you don't know the patient at all and you're starting from them, there's nothing that stops you from asking them directly what their concern is. Of course, you're going to explain to them what the problem is, and then ask them what their level of understanding is about the problem, and then start from there. It may well be, I prefer to give examples. I had a patient from Zambia who called in to see her diabetes control A1C was 14%, very high. And I saw that on my system, and I panicked, and I called her in to discuss options of treatment. And I was doing a consultation with my nurse, and 10 minutes into the consultation, she just wasn't interested in what I was saying. While I was worried about the complications of diabetes and all the things that could happen, She just wasn't listening. And so at a point I thought, you know what? I'm not getting anywhere. What's the problem? Then it turns out she was, going through so much, depression, domestic violence, and everything else was going on at home. And so the last thing she was talking about was diabetes. So we had to pack the A1C at 14% aside and deal with the more concerning issue at that time to get their attention. And so that kind of established a rapport. And so once we're able to resolve those social issues and the mood problems, we got her back in a couple of weeks later and then dealt with diabetes. And so knowing what is going on in their life at a particular time also helps. If you don't know anything at all, you might just think you're practicing medicine, offering what you think is the best, position when it comes to evidence-based medication. But actually, there is an efficacy gap between what you actually know in the textbooks and what, in the real world for somebody like that is going to be effective for them.
Thank you, Sam. So I think that's a great point, that it's not just about which questions to ask in itself. It's about knowing where that person's coming from as a foundation, which can then guide the next step. So the priority being, awareness to tailor any question or advice. And it kind of links with Hindi, your point about building rapport and making it a relationship that someone can actually share what's going on in their life, and that being a core part of it. Natalie, you've got the tough job actually of going last, because we've had some great examples of questions and approaches. So please go ahead.
No, I think I agree with both Sam and Hindi's points. And I think as a follow-up, I'd written down some points as they were both talking the most important thing in following up from Sam's point then, recognizing all those elements of that person's identity and social background impacts on that interaction in the consultation, but also what they do with their diabetes and medication, etc., moving forward. So once you've understood that, I think that's really important, because that affects their long-term engagement with medication, etc. So I think it's really important what Sam said, to pick up what we call in academic spaces or intersectionality, all the elements of their identity that are also interlinked to their culture. So their social context, all the things that may impact on how they can engage with consultations and medication and screening and everything else. But also I think most importantly is asking the person what works for them. So what actually does work for you? And also I think coming back to that notion that Hindi pointed up as us and them, I think it's important to be really honest, rather than denying that there are inequalities and there hasn't been difficult interactions across the NHS or across services nationally. Is to perhaps be upfront and acknowledge them. It might not be you as a clinician, and it might not be in anything that you've done, but it might be just honest to say, well, what works for you and how could we do better? And how could I do better? And I think in my own experiences and in also research data, that's where the patients and individuals have been most satisfied. And when they haven't been able to meet individuals of their own race, ethnicity, or background, those individuals that have done that have been more successful at reaching more cultural competency. So asking them what works for you, and given, for example, as Sam said, that individual has all those home circumstances going on, if you ask them what works for you, this is what I can actually do in my current climate. I can't do more than that, and I can't even come to a virtual appointment. So I think that would be important. And for example, more recently with the impact of COVID, I've found within the research collected that lots of African and African Caribbean people, particularly elders, have found it difficult to interact with virtual appointments and are not accustomed to virtual technology. And so when the clinician has been offering them virtual appointments, it's not been acceptable for them, and then they've just cut themselves off. So in that context, it's trying to, yes, we're in a pandemic, but asking them, well, what would work for you in the future with it, wherever they can. But again, it's what works for you. So I think it's that importance, but also in the context of that person's culture, tradition, beliefs, and practices.
Absolutely, Natalie, fantastic points and well explained, as as always. And just a small change to just asking a question. Does this medication fit in with the food that you normally eat? Would you have any problems adapting your food to match this sulfonylurea I've given you? Or just those type of things can make all the difference in a person living with diabetes. And as a final question before we move on to, further resources, Hindi, have you ever experienced that when you've been in a consultation or an interaction and someone has actually tailored what they're saying to you, and how did that make you feel? If it happened, I'm hoping it happened.
Not really. I think the closest I've come to is being talking to about Asian foods, which is more, and I'm like, I know we've got our spices and African foods and everything, but it's not the same. So I just said, no, personally, I don't actually like Asian food. Not that, there's anything, but I like my African food. I haven't, you can't tell me, the curry, or you can have dal, you can have lentils. I don't like lentils. So it's not the same thing. So that's the closest I've come to discussing my food in terms of different ethnic foods that will be discussed there, but not really, no.
Well, I hope as a result of this event that we've opened up the conversation and that you will have an interaction like that in the future. Like I say, I've only had a handful, and I've left the doctor's office or the healthcare professional office feeling so happy that someone has done a little bit extra research. And even, I won't go on, but it just makes all the difference. So last question. In this segment anyway, are there any resources to help people going forward? I'm going to go to you, Natalie, first, because I know you definitely have a resource. So please go ahead.
So within our talk today, there is a slide with some additional academic references that you can follow up on and have a look at. But within academic research, there is a limitation or there's limited studies within this field for African and African Caribbean groups. So we know we need to do more to expand knowledge in that area. But also there are different resources that are accessible through the health service regarding cultural competency and training, etc., that you can access. But also within the slides is the continuum that you can look at, and there are different resources. And there's resources that are accessible at the Leicester Diabetes Centre that I was involved in, which relates to booklets and culturally competent booklets regarding food plate tailored to African and African Caribbean groups. So there's resources that are accessible, but also come back to us if you have any questions. More than happy to help and provide guidance where we can.
Brilliant. So thank you. We're now going to move on to take some questions from the audience, which I'm sure are going to be extremely interesting. And while we're answering those, please continue to put questions and comments in the chat and we can address those. So we had a number of questions in advance, which were kindly submitted by people who registered for the event. So we have a first one. I think it's a perfect example of the type of question which might be uncomfortable. And I'm going to go straight to Dr. Samsiedu with this one. So the question is from Jacqueline, and it's: how would someone go about discussing erectile dysfunction with someone of African or African Caribbean background? It's a sensitive one.
Thank you, Bernie. It is a sensitive one for anybody from any culture, not necessarily African or Afro-Caribbean patients. I suppose the best way to deal with it is deal with it like any other complication of diabetes. And so I go with a straight face and tell them about the complications of diabetes. I don't go straight for that particular complication. I normally start with the other complications that are easier to talk about, those macrovascular complications, list them, and then work my way down to ED. Once I get to the erectile dysfunction, they would have realized that this is serious business. It's not to get them out. I've talked about other things, and this is one of them. And actually, that may well be what they are most interested in. and I will address it. Now, if they happen to volunteer that information themselves, and that will be rare because they will not volunteer it because it's a sensitive issue. But if they do, again, I'll make them feel very relaxed by taking it on board and, reassuring them that, look, you're not the only person. A lot of people, there is some statistic that say that 40% or 50% of men over 50 have got some concerns with erectile dysfunction. They just don't go tell everybody. It's a personal thing that everybody keeps to themselves. So maybe if you put it that way, that will reassure them that they are not alone in that. And then you can explore it further and suggest other intervention that may be useful to them.
That's great. Thank you, Sam. And Natalie, I just wondered, out of interest, is there anything from your research which could give some guidance around this topic or how to broach this I guess, extra sensitive type of conversation?
I think the most important thing is being sensitive to people's belief systems as well. So being aware that different cultures, traditions and practices may be relevant to the discussion. So again, as we said in the video, asking that person about how they feel, understanding what's important to them, why it may be an issue, and trying to make it as comfortable as possible. I think that's the most important thing, and just trying to understand how cultural beliefs, stigma, anything surrounding the topic can be addressed.
Thank you, Natalie. We have a question from Michael. It's along the same lines, but it's how to broach alcohol consumption. Are there any cultural things relating to African or African Caribbean that we should be aware of?
Again, it's not specifically any differences, but I think from my perspective, it's more of how to quantify the amount of drink. It depends on what they drink, and if you quantify it in English, talking about units of alcohol, that makes no sense at all to my colleagues from Africa. The types of alcohol that they may be drinking, you couldn't possibly quantify that in units. So it might be a good idea to probably establish how they quantify the quantities they drink, and then deliver the advice based on those. If you tell them not to drink, say more than a bottle of whatever they drink at night, that may make more sense to them. And if they drink a different brew from wherever they're coming from, some of them may actually be difficult to quantify. So maybe just, broaching the topic in a more sensitive way, establishing how much or what the strength of the alcohol they take actually is, and then trying to work out how much of it they take, rather than giving them specific units sizes. I think that is a way of dealing with it.
Yeah, I think that's important. I think in the chat as well, Charles mentioned something about COVID and developing a beer belly. So I think especially in the current climate, recognizing the impact of alcohol consumption during lockdown and in the current climate with limited access to other social activities, I think being sensitive to that is important. And also recognizing within particular cultures, picking up on Sam's point, is the notion of free measures. So free pouring and asking someone perhaps from an African Caribbean background, how much is the unit or how much have you had, is very difficult, I think, but being respectful of that and trying to understand from their belief systems or their practice or their cultures. I think that's important.
Thank you for that explanation. And I do agree wholeheartedly. In all of my family interactions, any celebration I've got, I've never seen any mention or talk or consideration of a unit of alcohol. It's just not something that's built into the culture. I guess a final question from the ones that are sent in advance was, how do we broach the psychological effects of living with diabetes, and would there be any cultural implications for that? I know it's been said a lot, I've heard a lot that the stereotype is Africans don't have depression. We know that's not true. Can I come to you first, Natalie, because I know that you've done some work in this area, to answer the question, please?
Yeah, I think the important thing, which I've written about in my book that's coming out in July, is about um, gender identities and belief systems and cultural understandings of mental health or mental well-being, and particularly within African Caribbean males, the notion of not discussing mental well-being or mental health, and also keeping that to yourself. So having that difficult conversation and how that's impacting perhaps on the person's diabetes, pre-diabetes, or management is perhaps not going to come out in a traditional consultation, and also may not come out unless accompanied by another family member or raised by another person within that consultation. So being respectful, I think, or aware of the cultural understandings around that particular perception of mental health is important, and trying to consider how to discuss it, consider whether there are alternative options, like we've mentioned already in the conversation about social prescribing pathways, access to dominoes clubs, access to cricket, or lots of schemes that could make a difference, but also being aware of those cultural differences is important.
Wonderful. Thanks, Natalie. So we've had we've got a question, another question. Is there a difference in how to assess, review, and manage emotional health in people of African origin? Are tools such as DDS, PHQ validated in those populations? So that's a toughie. I'm not sure. I guess Natalie would be the one to go to for this.
I guess it's the same issue that's being raised within clinical trial data surrounding diabetes and Black African groups in particular within the UK, but also currently in COVID trials, and the percentages of Black African populations within the trials. We know the numbers are low and are slowly improving through different targeted schemes. But again, those tools, some have a minority group, but again, in the same with clinical trial data, the numbers are low. And I think moving forward, if there's one thing we can work to do and hope to do within our research and practice, is try to improve that data and try to look at how the tools can be validated. I know myself, when looking at screening tools and using them on different ethnic minority groups, the lack of cultural competency in asking the questions, particularly with African groups and South Asian groups, there are certain practices within those measurements that aren't applicable and need to be explained within the context of their lives. So I think we need to do much more within the UK to address this.
It is putting you on the spot a little bit, Natalie. Can you recall one of the questions that you encountered that you felt wasn't quite applicable in certain populations?
I can think of it in terms of physical activity screening questions. So, for example, having done some research on looking at physical activity behaviours in South Asian women, for example, not in this case, this study asked some questions about physical activities and includes questions that relate to gardening, etc., and going outside. So for cultural practice or belief systems, that female may not be able to go outside unaccompanied and do certain activities due to cultural perceptions or beliefs. And that can also translate to other groups and be relevant for African populations following particular belief systems or religions. So therefore, those types of screening questions don't work because they're not relevant to those individuals. So I think it's thinking about it. But I think there's definitely more discussion that we need to have. And I know Sam may have some answers to this as well.
Yeah, Natalie. So like everything else, when you're talking about the Black race, the common mantra is there is no data. So we have been using PHQ-9s a lot in assessing depression. PHQ-9, by the way, is Patient Health Questionnaire 9, which we use to assess depression, certainly in primary care. And I'm not aware of any data looking at this. There may well be some, but I'm not aware of that in validated in the Black population. With diabetes distress syndrome, again, the data, even in the majority ethnic groups, it's not as great. It's an area that is being explored. So I'll be very surprised if we had, a data on that validated in the Black population. So it calls for more research to be done in this area.
Wonderful. Thank you very much for that answer, Sam and Natalie, and also for everyone in the audience who joined. Please look out for a follow-up email. We will be sharing a link to the recording of the event. And if you're not already a member of Diabetes Africa, please do sign up at diabetesafrica.org. This has been the first event in a series of 5, and we have another event tomorrow where we're going to be talking about getting the diagnosis right for people of African and Caribbean origin. So I hope you have a lovely evening, and thanks for joining us today.
Don't take it personal.